Leah is a family physician and the new academic director of Black Health within Dalhousie's Faculty of Medicine. She was born and raised in Dartmouth, attending Dalhousie for medical school and graduating in 2018. After attending McMaster University for her family medicine residency, she practiced in Ottawa, hey, my hometown, for 2 years prior to coming back to Nova Scotia. Her role in Dalhousie's Faculty of Medicine is working to engage the African Nova Scotian Black community with the university to increase representation of Black medical students, advise on curriculum as it relates to Black health, and to support working towards a culturally competent learning environment. Clinically, she is working in primary care for the Nova Scotia Sisterhood, as well as in addiction medicine. Leah, welcome. We're looking forward to hearing from you. Dr. Ruth Lavergne is an associate professor in the Department of Family Medicine at Dalhousie University. Her training is as a PhD researcher, and her expertise is in quantitative analysis of health system data. She works with experts in qualitative methods, patients, care providers, and policymakers on studies that look at primary care across provinces and over time. Her research aims to address disparities in access to primary care and build evidence to ensure primary care organization, delivery, and workforce meet the needs of people in Canada now and in the future. So Ruth, Leah, welcome. I'm going to turn it over to Ruth, who is going to share her deck and will kick us off.
Hi, hello. So yeah, I'm Ruth. I'm a researcher and I'm going to be offering my perspective, which tends to be pretty high level, like at the systems level. And then I'm really excited to be able to throw to Leah, who will be able to speak to experience as a clinician and different vantage points on some of the same questions. And then it'll be great to have discussion together. So I want to talk about what primary care is, just how I think about it and why I think it's important, what it does within health systems, some details about how it's organized and paid for, and I'm always happy to answer more questions about this. And then I'll answer a question that I get a lot and that I know like friends and family grapple with is just why it's so hard to find a family doctor or another regular place of primary care right now in Nova Scotia and across the country. So I'm going to jump right into it. So when I think of primary care, I like the image of a front door. This isn't mine. This comes from a reporter on healthcare. But if it's working well, primary care is the part of the health system that you know you can go to. It's welcoming. You can walk right in and get directed where you need to go. And that's if it's working well. We know that's not the case for everyone. And in many cases, it's not even clear where the front door is to the health system. But my goal is for everyone to have a place they know they can go to that's welcoming, that meets them where they are, and that gets them sorted with whatever they need. I'll also maybe sometimes use the words, or you might hear the words primary healthcare. And just because academics like to do this, it has a slightly different meaning than just primary care. And that is a vision of healthcare that also includes public health, that's closely connected to communities, that's attentive to social determinants in economic contexts, and so it's even broader than primary care as it sort of looks in Canada. So that's something to tuck away. This is an old photo from when this idea was initiated as a goal for health systems worldwide. And in many countries, there is this close connection between public health and health promotion and the things that really make people healthy and healthcare. In Canada, that's a little bit more distant. So that's maybe something to think about. So when I use the words primary care from now on, I really mean that. I mean this sort of narrower sense of services from a family doctor, nurse practitioner, or team. So what does that look like in Nova Scotia? My hope is that some of you can recognize the types of places you might get care in one of these images at least. So we have a few different options that all fall under the umbrella of primary care. So some people might receive care from a publicly operated clinic. A clue to this would be that there's the Nova Scotia Health Authority logo somewhere on the door or somewhere on the premises. So that would mean that it's publicly operated in that the health authority owns or rents the space. They organize many aspects of the care and they might employ physicians and other team members. What the team looks like could be a little bit different, but there is this public role for planning and organizing. You might also receive care from a privately operated clinic. So this could be rented office space. This would suggest that there's a family doctor usually who's getting public payments, so is being paid by the province, but who's renting the space, hiring staff, and organizing care themselves. Sometimes, so I've got an image like co-located with a Lawton's. Again, so you might be going to office space or a medical professional building. Those would be privately operated clinics, but they're still, you're not paying out of pocket. They're being funded by the province. Then another option would be a walk-in clinic. I think many of us have experience where you can't get in to have an appointment or you don't have a regular doctor, and this is a place that you can go to for urgent needs. It's also sometimes the same place as people get regular care. In this, you'll notice that it's actually the same photo in the same place where they just opened a walk-in clinic in an otherwise privately operated clinic. So they kind of blend together. Then I've included a picture of an emergency department because for many people, like when we have frontline needs, that's an obvious place to go that's going to be open 24/7. And so maybe delivering primary care when we need it. Then turning online, in Nova Scotia, we kind of have two different flavors of virtual care as well. If you are on the Need a Family Practice Registry, if you don't have a regular family doctor and are waiting for one, you may have experience of accessing care through Virtual Care Nova Scotia, where you can log in and see a doctor online or a nurse practitioner in some cases, and you're not paying for that. Then finally, some of you might have experience using Maple or another online sort of virtual walk-in clinic where you have been asked to pay for an encounter and are seeing a doctor. So all of these totally count as primary care, but I'm going to talk a little bit more about what distinguishes them, what each of them are doing, and what's sort of behind the scenes of each of them as my talk goes on. I just wanted to add a few more photos. Again, a couple more public options. So you can see the Nova Scotia Health logo and the clinic in the top left. There's the clinic where Leah works, the Nova Scotia Sisterhood Clinic, located with the Brotherhood Clinic. There's a picture of a bus. One of the things recently rolled out was an urgent care bus funded publicly. So it can look lots of different ways. I'm curious if you can't really map on where you get care into one of these options, I'd love to talk about that more in the discussion and we can maybe sort out how it's structured. Okay, so what does primary care do? Most obviously, it's that front door element, right? It's that first contact access. You have a new health concern or you need help for an ongoing concern, and it's a place you know you can go and access care. So that's obvious. We hope that it's pretty comprehensive. So we hope that it can meet most of your needs, or if it can't meet your needs, there's a mechanism to refer you to care elsewhere in the system so that your needs can be comprehensively met. But that's not it. One of the two things that I really like to emphasize are that it's also supposed to be continuous. It's supposed to be following you over time, knowing your story, your medical history, keeping a record, so that when you come in with something new, there's context and there's knowledge about what your past medical experiences look like. And that's what we call continuity. And then obviously coordination. The health system is complex. And so if it's working well, primary care is helping you navigate that complexity. It's coordinating your care when you need to see a specialist, when you need imaging or lab testing, and making sure you're where you need to be at the right time. We know it's not always quite that simple, and that many of the frustrations we experience within the health system are when that coordination falls short. And I want to keep these 4 functions in mind as we go back through those different options of primary care. So in both those public and privately operated clinics, if it's a place you regularly go for care, then it's providing you that access. Hopefully it's reasonably comprehensive. They're maintaining your record and following you over time. It's continuous. And hopefully they're coordinating care when you receive services elsewhere. So whether it's owned by the health authority or owned by or operated by a private physician, it's doing all 4 things. Switching to the walk-in clinic, it's that first contact access, but what might not be happening is that continuity or coordination, and they might not be able to offer comprehensive care for all needs. Like maybe the walk-in clinic doesn't manage pregnancies, for example. And then finally, the emergency department, again, obvious for a point of access, And also kind of reassuring in that it's comprehensive, right? Like, you can access all the resources of the hospital, but it's also not delivering on that continuity and coordination, which sort of limits care for people who are only able to access services in the emergency department. And then those two virtual options where you're seeing a different provider every time on a virtual platform would be like the walk-in clinics, where there's access, but they can't do everything online. So it's not comprehensive, it's not continuous, and it doesn't really coordinate care. So keep those four functions in mind of primary care. One of my frustrations is that sometimes politicians talk about primary care to keep people out of the emergency department, which is important, but it really only gets at that access piece and not at really supporting continuity and coordination, which I think is where the value of primary care really lies. So there's three main ways that we often think of paying for primary care and other health services. So the most common, and still in Canada and most longstanding, is fee for service. So a payment is for each service provided. These are usually negotiated between the health ministry and the Doctors Association, because it's usually payments for doctors. And they cover both the clinician's time and also expenses to run the clinic. So that's the traditional family doctor's office. I've got the little Band-Aid icon here because it's just a payment for that one specific service. Then a model that we see in some settings, including often in community health centers, is what is called capitation, where the payment goes to a physician or a group of providers or a community health center for each patient registered under their care for a specified time period, usually a year. And ideally, if it's working well, the payment should be adjusted for factors that shape complexity of care. So people's age, sex or gender, and health conditions. So I've got little people in the icon here because it's a payment corresponding to a person. And this can be a little bit more flexible for something like a community health center to operate, because they know what their budget is for a patient population and can make decisions on staffing accordingly. And then finally, salary is a way that some providers get paid. And it's like anyone else, they've got like the check up at the top because it's for a number of hours or for expectations over the course of a year. And this would typically imply that a physician or care provider is a salaried employee of an organization. So they're not running their own clinic, they're an employee of an organization, and would have a contract with them. Or it could be just a contract that corresponds to a set amount of time. So a doctor, a nurse practitioner, a team member of a community health center might receive a salary from the community health center. It's also possible to combine more than one of these payments types. We don't really have that in Nova Scotia right now. In Ontario, for example, a lot of people are paid on a combination of fee for service and capitation. And then sometimes governments try to have incentives or bonuses within these payment systems. But there's often a lot of conversation about how we pay for primary care. My little editorialization here is that payment is important, but we are not going to fix the system through payment alone. But it's important to make sure that we don't have a payment model that's working against what we want to do organizationally. So I wanted to mention these payment types. So then going back to those clinic types, in a publicly operated clinic, they might be in some cases receiving a budget through capitation, but it's also likely the case that individual providers are receiving a set salary that's predictable each year. There's a little bit of variation here though. Sometimes there are clinics where the health authority operates it, people get fee for service and pay a part of that into the clinic operations. So there's no hard and fast rule here. This is just what tends to be the case. For the privately operated clinic, some are capitation now in Nova Scotia, but that's a fairly small number. Most are fee for service, where they're getting a payment for each of those services delivered. Same thing in a walk-in clinic. It's simply billing the province each time you see a patient. And then in an emergency department, it varies a bit, but often folks are salaried employees of the emergency department, or they might be billing service. So it doesn't map one-to-one. We have combinations of different payment models and different clinic models throughout the province, just to keep it confusing. When we're looking at virtual care&S though, that's a different model. People get set amounts of payments for time. And when you're paying privately, I've got a little different icon here. That's just out of pocket. You're spending money directly on the platform. That's a little bit of payments. Looking across the country, Nova Scotia actually, so we could divide this into that traditional fee-for-service payments and capitation or salaries or other alternate plans. Nova Scotia has a little bit higher uptake of alternate payment plans than other provinces. So that's this often kind of a salaried model where there's expectations corresponding to a contract. So who is providing primary care? We think often of family doctors and nurse practitioners, and I've definitely said family doctor a whole bunch of times here. But if it's working well, it probably involves a bigger team. So administrative staff are key to all of that coordination and continuity. It could involve registered nurses, social workers, dietitians, licensed practical nurses, pharmacists, and oftentimes it's a place where people are learning to be clinicians as well. In Nova Scotia, we're moving towards more team-based care. So there are approximately 100 collaborative family practice teams, and just this week they announced more. The Nova Scotia definition is that a clinic is considered collaborative practice when it has 3 or more primary care providers with 2 or more different types of health professionals. So this is one thing I want to emphasize, is not everything that's called a collaborative team is like 10 people with lots of different skills working together. Sometimes it's 2 doctors and a nurse. So it falls on a wide continuum. But if when you go to your clinic, you see people who are other than the family doctor, then it's probably a collaborative team. We have stats just again to show that it really still is a lot of family doctors, a fair number of nurse practitioners, some registered nurses, but we don't yet have piles and piles of social workers, dietitians, LPNs, or other team members working in the province quite yet. Health spending. We spend a bunch on health. This is the breakdown of the provincial budget. This has been a focus in the province, focusing on fixing healthcare and giving people more options has been a priority for the current minister. But this breakdown of sort of roughly a third of budget sort of is typical across provinces. How it's organized is important and also connects to funding. So in Nova Scotia, as with other provinces, the federal government doesn't do much with respect to health. They were never really supposed to. That's built in from the start. They provide funding, but they are not responsible for care or delivery. There's the provincial government, who one department within it is health and wellness. They are sort of directly responsible for funding services. They actually plan, organize, and administer some programs directly, but oftentimes they support and delegate care to Nova Scotia Health and the IWK. And then it's Nova Scotia Health that's most active in primary care, planning and organizing those publicly administered clinics across 4 geographic zones. So who's responsible for primary care? I'm being a little bit cheeky with this slide, but this dynamic does kind of play out where the federal government is like, oh, it's totally not me. And the province is like, look over there, it's the health authority. And the health authority is like, province and federal government, where are you? And then the individual clinicians are like, well, we actually have a role. What's happened? So I think we should be attentive to this dynamic and its context that I think you can't escape for primary care, that who's in charge is often subject of debate. So then for any of the policy nerds out here, this is just a little bit of a context to explain how we got to this kind of situation. If this is too much detail, then just look out of the beautiful window and see what's going on. So again, it's from the Canadian Constitution that we get this situation where provinces are in charge of health and the federal government doesn't really have a role. Back when the Constitution was established, healthcare wasn't all that prominent a responsibility. So it's this legacy that's carried forward that the provinces really lead the show. I also want to make clear that it is within the framework of our health system that inferior care has been provided to Indigenous people in Canada. Racism is baked into the system from the start, placing jurisdiction for people who live on reserves under federal jurisdiction, unlike everyone else who's getting care from the province. So that separates systems with inferior care is again structured within our healthcare system. Our current system where the public is paying, so public payment, but private delivery from individual physicians dates back to the 60s. So that's when you might have heard of the Saskatchewan doctors' strike, where there was tension about direction for public delivery of primary care in Canada. And doctors wanted to work independently, but we wanted a public system. So that's where we get this private physician delivery and public payments. And then finally, the Canada Health Act in the 80s reaffirmed public coverage, but only for hospitals and doctors. So that's why we get this tension where doctors are covered for primary care everywhere, but there's a lot of variation across provinces in terms of what other team members are involved. And then I'm just going to take a couple moments to answer this question and then hand it over to Leah. So why is it so hard to find a regular place for primary care? It surprises many people I talk to know that there are more family doctors than ever before in Canada. That's true. So the green line is Nova Scotia, and we've actually always had like more doctors than average, but it doesn't really feel like that. The perception of a shortage of primary care or family physicians is widespread, and you'll see more from the survey results later on those experiences. So it is true that on average, the number of patient visits per doctor is falling, and it's falling in Nova Scotia and in other provinces too. And so when I try to answer this question, I try to emphasize though that it's not just that family doctors are working less or that primary care providers are working less. The work family doctors do is changing. Population needs for primary care are changing, and the systems within which primary care providers work are changing. And these are all things that you're going to have to contend with as we think about what primary care should look like going forward. So on average, doctors see fewer patients. And this is true across provinces, across age groups, and across genders. So it is not simply the case that there are more younger physicians who are working less. It's true across ages and generations. Many family doctors are doing different roles. So some are working in emergency departments, coordinating care in hospital, or filling in other gaps in care, like services for people who use drugs, who require medical assistance in dying, providing palliative care. And a small number of family doctors are providing services that people have to pay for, like those virtual walk-in clinics or Botox or things. That's absolutely a thing that happens, but the numbers are small. I want to also emphasize, as you're thinking going forward, that population needs are changing. We know the population is aging, but that doesn't tell the whole story. People are being treated for more conditions at older ages. People are getting more prescriptions and imaging and lab tests, and all of that means more work in coordinating care. And people are spending less time in hospital, which is awesome, but it means they're spending more time in the community, which has implications for primary care. And then, so yeah, and Nova Scotia, we all know, is aging a little bit faster than other provinces and is older on average. And health status in terms of perceived health or perceived mental health, also just a little worse in Nova Scotia than other contexts, which shapes primary care needs. And then finally, the systems in which primary care providers work are changing. So we know that referral processes are complicated. Family doctors spend a lot of time coordinating care in advance of visits with other specialists. Finding specialists who will take referrals and navigating forms and processes is time consuming. And electronic health records don't necessarily fix this or save work. So all three things are happening simultaneously to shape that gap between more providers and less access. The final thing I'm going to leave you with is this isn't happening the same for everyone. When we look at income, whether you own your home, whether you've immigrated to Canada, and whether you're racialized as non-white when you encounter healthcare, there have always been gaps in access, and those are either persisting or growing wider. So it's not a good news story with respect to who has a regular doctor or a regular place of care. Inequities exist, and they are getting worse and not better. And so that's something we really need to be attentive to going forward. Thank you so much for bearing with me up to this point from my academic perspective. I'm going to throw to Leah now, and then we can have a broader discussion. I'm excited to catch up on those questions in the chat.
So we're going to quickly just go over, I know Ruth has covered a lot already, but if primary care works well, what does it look like? And in turn, what does the health of Nova Scotians look like currently? Next, we'll touch on how COVID affected our healthcare system, or even still revealed cracks in our healthcare system, and why they're so important. Okay, so next slide. So if primary care works well, to me, a well-functioning primary care system in Nova Scotia would prioritize the needs of the community. So that's why I think this project is so important. And it will have a focus on high quality, equity, and patient-centered care. I also picture it as collaboration between a lot of different healthcare providers, which Ruth touched on. In my training background, I went to McMaster, and I practiced in a family health team where there were multiple physicians, multiple learners, so medical students and residents. There were nurse practitioners, LPNs, pharmacists, social workers, all in one space, as well as the admin team. And it was a beautiful example of how healthcare, or primary care specifically, worked well. And when we think about primary care, we think about health promotion. So giving people the tools that they need to increase control over their health individually, as well as in the community. We can also look at disease prevention. So primary care providers can encourage lifestyle changes for people so they can live the healthiest life they can. And also, give education, such as well baby visits. There's lots of education that goes into those. So really, when I think about primary health providers, I think of myself giving education that I have had the privilege of receiving through medical school to my patients. Next would also be disease prevention, early disease detection. So things such as cancer screening or doing routine blood work to check to make sure that you don't have diabetes. Next would be chronic disease management. So should you have diabetes, we would make sure that you're on the right medications, refer you if you needed to be referred, but also monitor your health and well-being by doing regular blood checkups. I love the door analogy. So primary care, your family physician, your nurse practitioner, whoever provides your primary care, is like the door to the healthcare system. So we're able to navigate for you, help you get to where you need to be if you're able to get to that door. And like I touched on previously, the interprofessional team. So next, Kate. So really looking at this all, we have to be sure that the Nova Scotia population, everybody has access to care, continuity of that care. If you have access, you want to have quality care, right? So sometimes we were already talking about people feeling rushed by only having one thing that they can talk about in their 15-minute appointment. If you have good access and good quality, then patient experience is going to be better, and in turn, health outcomes. We also have to be very cognizant about how different communities are affected by lack of access to primary care. So it needs to be purposeful, prioritizing equity and addressing health disparities throughout Nova Scotia. So next slide. So how healthy are Nova Scotians? Next. So first, let's look at our population. I liked this slide because everybody's talking about like the boom of COVID. After COVID, a lot of people have moved to Nova Scotia, but the start of this slide is 2000. So we were kind of hovering around that 940,000 population base here in Nova Scotia, but around 2017, we've had a steady increase in our population in general. So obviously more people, there's going to be more need for healthcare services. The next slide just shows also the distribution of age. So Ruth touched on this as well. I'm a very visual learner too. So to 1991 is the yellow bars. There was a lot more births and a lot younger population versus 2020. There's a shift here that you see. Most of the people, the bulk of people are in their older ages, right? From 45 to 65 plus. So with that comes more health need. As we get older, more chronic disease. So there's longer need in appointment times as well. So the next slide. So I went through Statistics Canada and just looked at the self-reported health that people put down in 2021. Canada is the light blue and Nova Scotia is the dark blue. So looking at life satisfaction, in Nova Scotia, it's basically the same as Canada. About 92% have a very satisfied life satisfaction. In Nova Scotia, the next bar is perceived health, very good or excellent. So maybe a little bit less compared to the country. Life stress seems to be a little bit less, which is a good thing in Nova Scotia versus Canada. Perceived mental health to be very good is actually a little bit increased versus Canada in Nova Scotia, which is also nice. And then the last thing is a sense of belonging to local community. We rated higher than the Canadian average. Next slide. So then looking too at self-reported lifestyle in 2021 for Canada versus Nova Scotia. So there's things that we do day in and day out that can affect our health and well-being, as everybody here knows. So smoking actually is higher in Nova Scotia versus Canada. The consumption of fruit and vegetables is actually quite a bit less in Nova Scotia versus Canada. Heavy alcohol intake is higher here in Nova Scotia, which is not a surprise either because of some of the social, because of the East Coast lifestyle, people like to say, but there's a lot more drinking in our culture. BMI was self-reported to be less here in Nova Scotia. That's a self-report. Excuse me. Cannabis use is higher here in Nova Scotia. And as well, we see self-reported physical activity to be higher. So looking at these things, smoking is higher, which can increase your risk of cardiac events. So higher blood pressure can lead to potentially heart attack or stroke. Heavy drinking can have issues in that same realm, but as well as liver issues, cirrhosis. Cannabis use can have specifically a very impactful, especially for children and adolescents, impact the mental health, can lead to psychosis. So thinking about how we're living our life informs the wellness of our population. The next slide, please, Kate. So here we think about primary care, treating chronic medical conditions and screening for them. Just looking at this graph, it's a good picture also to see that in Nova Scotia, we're struggling with our chronic health conditions more so compared to Canada. So asthma, diabetes, hypertension, arthritis, and COPD are all much higher here in Nova Scotia. Next slide. And then two, we think about the leading causes of death. So what should we be targeting with primary care and good health care? Cancer is one of the leading, as well as cardiovascular diseases. Again, we're having a higher proportion here in Nova Scotia. So when I look at this, I just think, okay, these are clear targets for what we need to look at and how we have to think about improving the health of Nova Scotians, and primary care is well suited to do that. The next slide. So many of you might have heard of something called the social determinants of health. So health is not just your biologic makeup, it's not just your genetics, and it doesn't just mean you going to see your nurse or doctor. Your health is definitely impacted by social things. So this is an outline of the World Health Organization and how they determine social determinants of health. They have also shown that 30 to 55% of health outcomes are influenced by these social and economic factors. So it's really, really important to have a focus on this when we're thinking about how to make primary care better. We also have to think about health equity, which refers to the principle that all individuals should have a fair opportunity to achieve their full health potential, regardless of their social or economic status. So I'll quickly just go through these points and give an example of each. So first, education, access, and quality. An example of this would be having access to early childhood education and development. So in lower income communities, this might not necessarily be true, and this is something that would follow you throughout your life. The next is healthcare and quality. So not as much in Canada, but still affects my patients that I see. So health insurance. So sometimes I prescribe something and I think it would be the best thing for this person, but they do not have health insurance to cover it. So they are set up even before they even try this medication because of their social situation and their income. The next is the blue, so neighborhood and built environment. So an example would be like access to green spaces. Another example would be exposure to toxins and pollutants. So my father is from Whitney Pier, which is a primarily Black community in Cape Breton. The tar ponds were right next to the Whitney Pier. So that's one example of environmental racism and how that social construct can impact the health of a community. Social and community context. So again, I touched on racism being as a determinant of health, and that would fit in there. Another social and community context would be communities that are at higher risk of crime, for example. And last would be economic stability. So income and poverty level, which in turn can affect food security and access to food. So if you don't have the access to food that is healthy, you are at a disadvantage and it will 100% impact your health. So last two slides. So the next one is about COVID. So just touching on COVID in the current healthcare crisis, it's really important. I think everybody knows that it was a stress on our healthcare system. But really, what I see it as, it was a microscope or a magnifying glass to what has already been going on within our system. So overburdened healthcare workers, when this happened, there was such a stress that caused a lot of burnout within the profession. So lots of nurses, especially that were at the front lines of this work that, burnt out from all the stress of this. There were also delays in non-urgent care, which I know I'm preaching to the choir here in Nova Scotia, where people had delays in getting, non-urgent surgeries, down the line that can lead to needing an urgent surgery or needing to go to emergency department for tertiary care, we call it. So that has a downstream effect and we're still feeling it. COVID in itself put a major stress on individuals for their mental health, so anxiety and depression. There was an increased demand for mental health services and there just wasn't enough resources, and there continues to not be. And then the last point, I kind of labored on this already, is just that the health disparities that COVID uncovered between communities. So Indigenous communities, African Nova Scotian communities were affected more so than other communities here in Nova Scotia. So being mindful that all of these things, although they are a conversation with COVID, these have been happening way before then. And then my last point is just, why is it important? I think everybody can agree that primary care is important. In my first slide, going on about what primary care is and why it's important to me. It's the foundation of the healthcare system. It's really the door for people to come in, like Ruth said, but we need to make sure that people have access to that door. It's management and prevention of chronic disease so that people can live the healthiest and longest life that they can. But I also see primary care advocating for positive change, both within an individual person, but also systemically by addressing the social determinants of health that I mentioned. Yeah, so that's me.